Hello. This is the second of the two-part lecture series on Chapter 5, a neurosensory organization. I want to let you know before I get started, because I might forget, that when we get to slide 19, I did make some very, very minor changes. One was just a spelling. I misspelled foramina, so I corrected that. And the other was to put the numbers of the three foramina that drain the fourth ventricle. Magendie, there are two, so I put in parentheses behind it two. Excuse me, that's one. And then Luschka, the two lateral positioned ones, there are two of them. And so I just put those parentheses, two behind that one. So one behind Magendie, two behind Luschka, and just as a little cue to the number of them. So if you I did repost that lecture in this module, but if you you might have downloaded the old one, and then you'll notice that little inconsistency. Or if you prefer to, you can download and print, or however you're doing it. Just to cue you to that. So anyway, we're going to cover slides 17 through 37 in this lecture, and the last 5 are a quiz question. So we're not even actually going to go over that. I'm not going to go over them and record that. Let's do that in class. And so if you have the opportunity, you should try to solve those, which you most likely can, because it sort of comes directly from the material. There might be a problem solving one or two in there, but most of those quiz questions do come from the material. So the information is there. So anyway, let's get started. Let me share my screen. I'll find slide number 17 and get started. Here we go. And I'll make that big. And here we go. So this is this particular image or figure does come from the book. It is figure 5.4. And what it shows is the cranial nerves that we're concerned with that have sensory function. These are cranial nerves that are involved in speech production or in swallowing. The next slide will show all of the cranial nerves that have any sensory function at all, but these are the ones that are concerned with speech, so I wanted to emphasize those. They're clinically significant nerves, and their function and their functions are tested by SLPs. Just as a quick overview, cranial nerve number 5, which is the trigeminal, subserves touch over the face and the oral cavity, including the anterior 2/3 of the tongue. I'm going to say this several times because it's very important, but let me say it right now. It's touch for the entire face. It's also, by the way, kinesthesia and proprioception and pain and temperature. But the thing that SLPs test would be light tactile stimulation or touch. So we're mainly going to be concerned with that, especially when it comes to testing. So it's the whole face. It's actually the top of the head too. And it's the oral cavity going back to the edge of the velum and down the sides where the fascial pillars are located, and then across the horizon of the tongue. If you just simply have somebody stick out their tongue and you look to where the tongue drops off in the back, that's the horizon. So that's sort of like a ring. Edge of the velum, fascial arches, horizon of the tongue. That is the area anterior to that where the 5th cranial nerve provides sensation. Now, cranial nerve 7 subserves the anterior 2/3 of the tongue for taste. So that information is going to be projected to a different nucleus subserving taste, the nucleus solitarius. Whereas the touch information, the general sensory information from the face and the oral cavity project back to the trigeminal nucleus. And we'll look at that. For plain touch, it goes to the main trigeminal sensory nucleus. And we'll break that down just in a little more detail later. Cranial nerve 9, which is glossopharyngeal, subserves taste for the posterior 1/3 of the tongue and also visceral sensation. Visceral sensation is the sensation that you basically have in your gut. So did you have sensation down there? Sure. If you, let's say, swallow a really big pill, sometimes you can feel it going down the esophagus. That's a visceral sensation. Or if you have that feeling that you're going to vomit, that's a visceral sensation. So we do, if you have a stomach ache, that's a visceral sensation. So visceral sensation is this type of sensation that we have through the gut. And that includes taste. So taste is one component. You don't have taste everywhere, of course, but you do have taste over the entire surface of the tongue. And that's all subserved by nucleus solitarius. And then, so we take the posterior third of the tongue, and also the upper portion of the pharynx is subserved for taste and visceral sensation by the glossopharyngeal nerve number 9. And then below that, visceral sensation is subserved for the lower portion of the pharynx and the larynx by nucleus solitarius through cranial nerve 10, the vagus. So those are the main speech and swallowing cranial nerves as far as sensation goes. Notice we haven't mentioned motor at all. That comes in chapter 6. Now this slide, which I think is number 18, shows all the sensory functions of the head and neck as far as the cranial nerves are concerned. So we've added a couple cranial nerves. We've added number 1, the olfactory, which subserves the sense of smell, olfaction. The first order neurons are located in the olfactory bulbs, which rest at the top of the nasal cavity. And they project back to, not to the thalamus. All the other systems eventually kind of get their way through the thalamus. Not this one. This goes directly to the cortex. But anyway, SLPs don't generally test this one. So I'm just mentioning it because we're going through all the sensory cranial nerves, but that's kind of it. Cranial nerve 2, the optic nerve in the visual pathway, projects to Brodmann's area 17. And we are going to look at that in quite a lot of detail in the last 2 slides in this series. It concerns SLPs because a lot of our patients will have problems with that system, with the visual system, that would affect reading, and even performance in tasks that we think of as language tasks. They are language tasks, but which require a visual component. For example, if you put objects out in front of a patient who might have aphasia and ask them to name the objects, clearly a language test. If they have a loss of vision in part of their field of vision, that's going to affect their performance. So we want to be very aware of it and in fact know how to test it. Cranial nerve number 5, the trigeminal, we went over that in the previous slide. So it does project from the face. Also, by the way, the nasal cavity. Now, we don't test sensation inside the nasal cavity, but it's the whole wedge of tissue, which I'll show you basically in the next slide. So I'm starting to introduce the idea that it's not just the skin, it's everything deep to that as well. They all project back to Brodmann's area 1, 2, and 3, or the postcentral gyrus. This nerve subserves general sensory functions with the actually proprioception and kinesthesia, that's part of general sensation, which projects back to a certain part of the trigeminal nucleus, the mesencephalic. We'll look at that in detail. Fine touch information is projected back to the main sensory nucleus of the trigeminal nerve. And pain and temperature information is projected to the spinal nucleus of the trigeminal nerve. And we'll look at all of those in a fair amount of detail. Cranial nerve 7, the facial nerve, does subserve taste, not general sensation, but taste, which is a special sensation over the anterior 2/3 of the tongue. And that information is projected back to the nucleus solitarius, which is located in the medulla. It does have some other minor functions. If you do some more reading on cranial nerve 7, you'll see it has some other sensory functions like sensation behind the ear, just little things that we're not going to look at all. The cranial nerve 8, well, that's obviously a sensory function, vestibulocochlear function, our hearing and our sense of balance. And we're going to look in some detail at that later on, not right now. But you also are studying that in audiology. So you have a couple opportunities to look at that pathway. We're not going to talk much about testing here because you do get extensive information about testing cranial nerve 8 in your other class. Cranial nerve 9, the glossopharyngeal nerve, subserves visceral afferent functions, including taste and general and visceral afferent sensation for the upper pharynx and the posterior 1/3 of the tongue. Posterior 1/3 of the tongue. All that information is projected back to the brainstem and the nucleus solitarius. And cranial nerve 10 subserves visceral afferent functions for the lower part of the pharynx, the larynx, the esophagus, and the trachea. And all of that information for visceral sensation is projected back to the same nucleus that 9 projects to, nucleus solitarius. All right, now let's look at some details of the peripheral part of the 5th cranial nerve. Well, the 5th cranial nerve is a peripheral nerve, but we want to look at the periphery of it more than the central connections in this particular slide. And you can see that the first point on your left is that it has 3 main branches: the ophthalmic branch, the maxillary branch, and the mandibular branch. I will point them out here in the image. Here's the ophthalmic, here's the maxillary, and here's the mandibular. The ophthalmic, now keep in mind, it's going to subserve general sensation. It subserves general sensation for the top of the head, the forehead, and the top eyelids. So basically, it stops at the corner of the eye, and it's the whole wedge of tissue. There are some images, if you would look this up on Wikipedia, just look trigeminal nerve Wikipedia, you'll see a color-coded image that shows the exact territory. But basically, it's a kind of a pie-shaped wedge of tissue that goes from the corner of the eye back to around the ear, and then this whole area up here. The maxillary subserves from the corner of the eye down to the corner of the lips and everything in front, like the nose, for example, and back in a pie-shaped wedge to around the ear. In this case, in the maxillary branch of the trigeminal nerve, it's not just the skin, it's also the roof of the mouth, all the way back to the edge of the velum, the back edge of the velum. It would be the upper teeth, the upper gums, the upper lip, the maxillary sinuses. You know, you get a cold and you feel pressure there, maxillary sinuses. The same holds true of the ophthalmic. It's getting afferent information from deeper areas, but you don't have a lot going on up there. You do have frontal air sinuses, and if you do get a cold, you can get congestion there. And you have feeling inside the eye sockets. That would be carried on the upper part from the ophthalmic branch. But we don't, as SLPs, we don't test those deeper areas at all. We do test light tactile sensation for the forehead, certainly. And then we go down to the maxillary and test light tactile sensation for the area below the eyes. But then we go deep too. We go into the mouth and test sensation at the roof of the mouth and the velum. So we do look at the sensation for the deeper areas for the maxillary. Same thing for the mandibular. Again, it's a wedge of tissues from the corner of the mouth back to the ear in a pie-shaped thing and under the chin. So this area here, and the floor of the mouth, the anterior 2/3 of the tongue, the gums, the lower gums, and the teeth. If you have a dental work that requires a local anesthetic, the dentist will inject behind your back tooth on the inside. So this wouldn't be out here; it would be in the mouth, behind the back tooth, in some soft tissue that gets access to about this part, not real close to the trunk, but halfway down or so, the maxillary branch. And then it will cause that part of the nerve not to carry any action potentials for a while, for a couple hours. And therefore you won't be able to feel anything. You won't be able to feel anything in the tooth that's being worked on that side, and also the whole anterior 2/3 of the tongue on that side. If you feel out here, you don't feel anything on that side. The whole area of the that's subserved by the maxillary, by the mandibular branch of the nerve. Okay, so now you know the 3 branches. You know what they subserve. You know that they're all general sensory in nature. They are all neurons that project all the way back to the brainstem. In other words, there's no synapse any place here. There is a ganglia This is a ganglion, just like the ganglion that is located in the dorsal root at the spinal cord level. You remember those contain cell bodies, but unlike the rest of our nervous system, wherever you see a cell body in the rest of the nervous system, there are dendrites and synapses. Not in the dorsal root, however. That's a cell body simply to maintain the life of the neuron. There are no synapses there. Same thing for this ganglion, which is called the Gasserian ganglion or trigeminal ganglion, located right here, fairly close to the trunk of the nerve itself. And that it serves the same function that a dorsal root ganglion subserves. Okay, now we're going to take a quick look in this slide at something we're going to look at again in the next slides, and that is the three parts of the trigeminal sensory nucleus. It has three parts. One located in the midbrain, which is the mesencephalic, and I'm going to try to point it out here. This isn't a real good image, but I've got better ones coming up. One down in the medulla, which is called the spinal nucleus of the trigeminal nerve, located down here. My arrow seems to be giving out on me. Here we go. And then the one that's a kind of a big round one, more or less, in the pons is the main trigeminal sensory nucleus. So you've got the main nucleus, the spinal trigeminal nucleus, and the mesencephalic trigeminal nucleus. I put in parentheses what part of general sensation each one subserves. The main trigeminal sensory nucleus subserves fine touch. The spinal trigeminal nucleus subserves pain and temperature. And the mesencephalic trigeminal nucleus subserves proprioception and kinesthesia. As far as testing goes, we're really just going to be concerned with the main sensory nucleus because we do test light touch. And that's probably all we can test. A neurologist would test pain, and they could even test kinesthesia. We could see the effects in a kind of a global way of problems with kinesthesia, but we don't really test it. Just one other thing, and this I don't think this shows it particularly well at all, but the first order sensory neurons enter at the pons, and it's a real big nerve. So we'll look at it. You'll notice it's when you look at all the different cranial nerves, this is a big one, and it enters the pons right on the side. And then the neurons, depending what kind of information they are carrying, will turn up toward the midbrain. Those would be the neurons that are carrying the proprioceptive and kinesthetic information. They'll synapse directly in the main sensory nucleus, and those would be the ones that are carrying fine touch information. Or they'll turn downward toward the medulla and form their synapse in the spinal trigeminal nucleus, and those would be the ones that are carrying pain and temperature information. Okay, let's go to the next slide. And this does show those the pie shape, but not very good colors, but there it is. Here's the ophthalmic branch, or the territory of the ophthalmic branch, the territory of the maxillary branch, and the mandibular. Okay, and then you see the Gasserian ganglion. We're kind of forgetting this right here. This is an extra little line that we're not looking at all right now. Same thing for this one. Forget it. Notice it's coming from the ear. We don't care about the ear. We just care about this. And it's showing the neurons enter the brainstem in the pons. Here it's labeled pons. And it just says nucleus of the trigeminal nerve. If it's the one in the pons, that would be the main sensory. But the main thing I'm showing this for is simply to show a pattern. The pattern is the same regardless of if you're talking about the mesencephalic, the main sensory, or the spinal. It's the same thing. And here's the point. The second order neuron crosses the midline, you see? So the first order neuron, and those are the neurons that make up the nerve, the first order neuron synapses in the main sensory nucleus, if it's for fine touch. And the second order neuron immediately at that level crosses the midline, and it joins all the other sensory neurons that are coming from lower parts of the body. Now, what are they in at that point? the medial lemniscus. Remember, we talked about the medial lemniscus. And when you get up to the level of the pons, the medial lemniscus has in it neurons that are carrying pain and temperature information, fine touch and proprioceptive information, and kinesthetic information, and all of the senses, the general senses. And they all go up to the thalamus. So here we're showing going up to the thalamus, forming a synapse. I do believe they label it here. Yeah, they just say the thalamus, and that's fine. So here's the synapse. And then the third order neuron projects out to the postcentral gyrus. What part of the postcentral gyrus? Well, since we're talking about sensation for the face, if you looked at where the sensory homunculus is, it's out here on the side of the postcentral gyrus, coming down fairly close to the temporal lobe. That's where it would be, the face area, So it's a 3-neuron chain to go from your sense organs here for touch, et cetera, into the pons, form a synapse in one part of the trigeminal sensory nucleus, depending upon what exact kind of information is being carried. Second order neurons cross the midline, join the medial lemniscus, and ascend to the thalamus, synapse, out to the postcentral gyrus. I do want to mention one other little thing. That third order neuron is making its way through the internal capsule. We've made a kind of a big deal about the internal capsule, and at some point I've said that the internal capsule does carry all sensory information to the postcentral gyrus in all its different forms for fine touch, proprioception, et cetera. The only thing it doesn't carry is olfactory information. Okay, so your smell does not go to, your sense of smell is mediated by the postcentral gyrus. It's mediated by part of the brain down around where the limbic system is located. All right, so I think we've got all the points made here. Let me just make sure. We've got the main trigeminal sensory nucleus. All second order neurons decussate to the opposite medial lemniscus, follow the same pathway to the postcentral gyrus that is shown here. Spinal trigeminal nucleus, not shown here, but I will show it in the next slide. I'm just going to make the point in writing here. All second order neurons decussate also down at the level where the synapse is occurring, and we'll look at that in detail in the next slide. And they ascend with, actually, if you think about the lower part of the medulla, there is no medial lemniscus yet. At that point, you have the lateral spinal thalamic tract, and you have the fasciculus gracilis and the fasciculus cuneatus carrying the fine touch and proprioceptive information from the body. So those three things. You've got those three things in the lower medulla. And then when the dorsal column system decussates at the mid medulla, they all come together. And from then on up, you have a medial lemniscus. So down at the lower level of the medulla, the pain information is projected to join across the midline with the spinal thalamic tract neurons. So you got all the pain information kind of in together at that point. And then the same thing for the mesencephalic nucleus. They project, second order neurons project across the midline, and they join at that point the medial lemniscus. You have a medial lemniscus in the midbrain, so that's what happens. Second order neurons all synapse in the thalamus, and the third order neurons all ascend through the internal capsule. That's an important point to the postcentral gyrus. All right, next slide. This one simply shows a nice clear image of that 3-part trigeminal sensory nucleus. The mesencephalic part up here labeled as such, that's clear. And I should probably point out the parts of the brain. Here is, from this point up would be, or this line up would be the midbrain. Obviously, a lot of the brain is not shown here, but we see the midbrain. We see the pons from this line down to a line here. Below that line is the medulla. So this is medulla. This is pons. You've seen it from a number of different angles now. This is a top view, and the cerebellum has been cut away. This circle here is a major connector between the brainstem and the cerebellum, and it's been cut on both sides. Brainstem, the cerebellum lifted away, and now we're looking down from a top view at the brainstem. This area is the fourth ventricle. The cerebellum forms the roof of the fourth ventricle, so that's the fourth ventricle. Here are other nuclei that we have looked at and we'll look at again, but right now we're just looking at this one. Notice it's pretty long. It goes the length of the midbrain, pons, and medulla. And you know now the functions of the three parts: mesencephalic, associated with kinesthesia and proprioception; main sensory trigeminal nucleus with fine touch; and spinal trigeminal nucleus associated with pain and temperature sensation. All right. Make sure I'm going to the right slide. Yes, I am. Okay, now, this looks like a mess, doesn't it? It looks kind of complex, but it shows in a picture form what I was trying to describe about the way the second order neurons cross over, depending where they are coming from, what of the three parts of the trigeminal nucleus they're coming from. Let's look at the main sensory nucleus. Here it's called the chief sensory nucleus of five. We kind of have a few different names for it, don't we? But they all kind of are similar in their meaning. So let's start with that. By the way, we're going to ignore these. These are neurons that are not crossed. In other words, it's an ipsilateral pathway up to the postcentral gyrus. We're going to ignore it because we're not doing anything with it clinically. We don't think about that pathway. The sheer numbers, not many neurons are depicted there, connote that it's not as important. And clinically it's not. So we're going to ignore it. So I'm only really trying at this moment to point out these neurons right here, second order neurons whose cell bodies make up the main trigeminal sensory nucleus. Their cell bodies make up that. There are synapses occurring here between the first order neurons and the second order neurons. And note, they're all sending their axons across the midline to ascend with other axons. This down here is supposed to be coming from it's the lateral spinal thalamic tract. It's one neuron shown that would be with the lateral spinal thalamic tract. So showing that the pattern is a little bit different down below. But let's go back to the main sensory nucleus right here. So they all second order neurons across the midline, goes to the thalamus. Here they've given us a little more detail about the thalamus. I don't care about learning that. It's the postural medial ventral thalamic nucleus. It's a part of the thalamus that gets these particular sensory neurons. And we're going to kind of not go to that level of detail. So just the thalamus is fine. Internal capsule and postcentral gyrus. So we have a 3 neuron chain there that's, for our purposes, totally crossed. All right, let's go to the pain and temperature one. Down here. So here's our spinal. And the spinal also totally crossed at the level of the synapse. So all throughout the whole length of the medulla, you have synapses like this occurring. What happens is this first order neuron that's destined for way down here in the bottom of the medulla and the spinal trigeminal nucleus, it enters in the pons and then it turns downward and travels in its own little tract down here till it gets to where it's going, and it forms its synapse. This is all somatotopically organized, and I think you know what that means now. So it's not just random, it's going down to a certain part, depending where it came from. And then the second order neuron leaves the spinal trigeminal nucleus and crosses the midline. Note all these different levels. In other words, they don't all somehow get together and then cross. They cross wherever they come from. So you have this pattern of crossing all through the length of the medulla going on. And the second order neurons goes and it joins whatever it can that is carrying similar information. So If you're talking about the upper medulla, there is a medial lemniscus, which has all the general sensory information in it. It joins that and goes up, somatotopically organized. If you look at that medial lemniscus, the toe is represented on one side, and the face, now that we've added face, is at the other side. And since we're down here in the spinal, we're talking about pain and temperature sensation. Recall that you don't have a medial lemniscus until the dorsal column system, which is with its fasciculus gracilis and fasciculus cuneatus, have formed their synapses in the nucleus gracilis and the nucleus fasciculus. The fasciculus, I'm sorry, a nucleus gracilis and the nucleus cuneatus, mid-medulla. And so after the second order neurons in that system cross, they come together with the pain and temperature neurons, and you've got a medial lemniscus. So below that, we do have some of this going on. What are these neurons joining? There is no medial lemniscus at the lower level. They join the neurons of the lateral spinal thalamic tract. It kind of makes sense because now you get to the medulla. The pain and temperature for the whole body is represented in that lateral spinal thalamic tract, and including the face once these start integrating into it down here, okay? So that's a kind of a minor detail, but the essential point is that all the second order neurons decussate. Okay, now let us use this slide while we've got it up here to analyze what will be lost in terms of general sensation with lesions in 4 different areas. First of all, this is kind of an easy one, I hope, the right trigeminal nerve. So let us imagine that the lesion is in the trunk. It's outside the CNS, but very, very close to it, so that in effect, all of the general sensory functions of the 5th cranial nerve on the right are disconnected. There will be a total loss of general sensation. SLPs will test in terms of fine touch. So you can lightly touch here on the right side. They won't feel it. You do it with their eyes closed. Ask them to signal when they feel it. And also you can, in a more detailed way, ask them where they felt it. In other words, touch the same area. Do it for here, do it for here, do it in the roof of the mouth, do it in the floor of the mouth. And they're not going to respond to any of that because they have been disconnected, basically. Let's move now. And then if you test any other dermatome anywhere, if that's the only problem they've got is the right trigeminal nerve trunk, all other sensation for all other parts of the body will be intact. Makes sense, right? It's just like if you cut the electric line to your house, but you leave the street alone, all your neighbors will have electricity, your house won't. It's exactly the same thing. So it's a very focused deficit in the territory of the 5th cranial nerve. Now let's move the lesion into the brainstem, and let's put it on the right side of the pons up to the midline. So it actually does destroy the main sensory nucleus, and it gets all of the neurons that are trying to get in and go up or go down from the trigeminal nerve. So you're definitely going to have the same pattern of loss that you have here, because if you put a big lesion right here, you're taking away all these functions for the 5th cranial nerve on the right. But you're also interrupting some other sensory pathways that are trying to get past that point. What sensory pathways? The medial lemniscus, which, remember, at that point, now we're up in the pons well above the decussation of the dorsal column system. It's all the general sensory information for the entire body on what side? That's the key thing. On the left. So you would lose all general sensation, fine touch, proprioception, pain, and temperature, on the left side of the body and the right side of the face. It's extremely telling. There's only one lesion that can produce that, and that's a lesion right here. So it's now, I want to back up and make sure you are thinking about why it would be the left side of the body. For fine touch and proprioception, where was the decussation? at all the different levels of the cord, wherever the pain information entered, it crossed. Wherever the neuron carrying pain and temperature sensation entered the cord, it crossed and ascended. So the loss is going to be on the opposite side because it can't get past this area of the pons. How about the crossing for fine touch and proprioception? That was at the level of the mid-medulla. The fasciculus gracilis and fasciculus cuneatus ascended up the cord, up the bottom part of the medulla, synapsed in the two nuclei, the nucleus gracilis and nucleus cuneatus. Second order neurons decussated all together and ascended. They joined the pain pathway and they ascended in the medial lemniscus. So you're going to lose all the general sensations from the left part of the body and from the right side of the face. Okay, now the next two are going to be easy. Let us put the lesion up in the midbrain. So the nerve, the fifth cranial nerve we've been talking about itself would be intact. The nerve is okay, but that you lose the functions. Why? Because they have to get through the midbrain in the medial lemniscus. They've all the second order neurons of all the systems of the whole body have crossed by that point. And so all the losses, since we're putting the damage on the right side of the midbrain, would be on the left side of the body. Left side of the body and left side of the face, left side of the oral cavity. Same thing for the internal capsule. If the damage is in the right internal capsule, all the losses will be on the left. And by the way, could you discern the difference between a lesion in the right midbrain and the right internal capsule? Yes, you could, but not by testing sensation. We'll have to look at other functions, and you'll see about that later, but not by testing fine touch, proprioception, pain, or temperature. No, you could not. All right. Now we're going to look at the glossopharyngeal nerve. We're not going to look in as much detail, and we probably don't test it in as much detail. It subserves taste and visceral sensation over the posterior 1/3 of the tongue and the upper pharynx. And this illustration simply shows the territory subserved, more or less shows the territory subserved by the first order neurons. Here it is, posterior third of the tongue, going back here and carrying information back to, if you look at this in detail, you can see it's the nucleus solitarius. And they form a synapse. We're not looking at the central pathways yet, but we will. And we test that basically by just touching the back of the throat, and you should get a gag reflex if this system is intact. And you would test the two sides. This is a depiction of the vagus nerve, cranial nerve 10, for visceral sensation in the lower part of the pharynx. It shows this somewhat lower part of the pharynx, and the inside of the larynx as well. And this shows the internal branch of the superior laryngeal nerve, and also the recurrent laryngeal nerve. Here's the recurrent. It's sending afferent neurons into the trachea and subserving areas below the vocal cords, I meant to say. And the internal branch of the superior laryngeal nerve subserves sensation in the area of the larynx above the vocal cords. First order neurons all go back to the nucleus solitarius. Same place where first order neurons of the glossopharyngeal nerve projected to. Okay, this is kind of an important slide now, and it's very schematic, but what it is showing is a very rough depiction of the nucleus solitarius here, and showing the second and third order neurons. Note the important part of what I'm trying to show here is that the second order neuron crosses. So if you have damage that involves this neuron, you're going to lose taste and visceral sensation on the opposite side. Okay, let's consider how that would play out. If the damage were of the right cranial nerve 9, there would be a loss of the gag reflex on the left because this crosses. This shows the posterior third of the tongue. It doesn't really show the pharynx, but remember the sensory territory of 9 is the posterior third of the tongue and the upper pharynx, the part that you would see if you just look in the mouth. You see the back wall. That's upper pharynx. The left cranial nerve of vagus, the vagus nerve, that's a little harder to test, although SLPs can and do it. Not everybody. You can do it if you do FEES. FEES is fiber optic endoscopic swallowing, evaluation of swallowing, and a flexible scope is passed into the throat just above the opening into the larynx, the adytus laryngeus, and then the individual swallows various materials that are all colored blue so you can see them well. And you can see that swallow. You can see if anything goes down into the airway. And as part of that test, some SLPs give a little puff of air, and they can test the sensation on each side by directing that puff of air into the area that would be subserved by the internal superior branch of the internal laryngeal nerve, or even the lower pharynx itself. And you can puff an air on that. It's what should you have? Well, you should have a reaction. And if you don't, there's a sensory loss. And if the lesion were up here someplace, that sensory loss would be on the opposite side. If it were down in the nerve itself, the lesion would, the loss of sensation would be on the ipsilateral side. So like I said, we can test that. Certainly an ENT can test it as well to see if there's a loss of sensation in the larynx and where it is. And then if there was a lesion in the right internal capsule, up in this region, the loss of sensation would be on the opposite. Okay, opposite side of the tongue, opposite part of the pharynx. All right. This is just a reminder, and I have shown you this particular slide before. It does not come from the textbook, but I kind of like it because as you're progressing through the cranial nerves, you can refer to this time and again, and it's just like a little reminder about the parts of the brain, midbrain, pons, medulla, what nuclei are located in them, and what the modality of the nucleus is, and what the name of the nucleus is, and what the modality. What do I mean by modality? Well, here's the oculomotor, trochlear, and abducens nuclei. Those are nuclei that control the striated muscles that move your eyeballs. You look to the right, look to the left, up, down, etc. Those are striated muscles controlled by somatic motor nuclei. Here's their names. Here's where they're located. And the one other one, strangely, it seems, what's it have to do with eye movement? Nothing. But hypoglossal nucleus controls the tongue. Your tongue grew from somites, the same developmental structures that gave rise to the muscles of your body, also your tongue, also your extraocular muscles. All the other muscles of control of significance to SLPs that we do our speaking and swallowing with are controlled by branchial motor nuclei here. Here's their location again, trigeminal motors, facial. We haven't gotten to those, what we do in chapter 6. That's why I like this, and I'll show it again in chapter 6 because it's a reminder. Nucleus ambiguous and spinal accessory. All these muscles that we do our speaking and swallowing with, except for the tongue, grew from the branchial arches. I think you learned about the branchial arches in your anatomy and physiology course. The visceral motor ones, we're not paying much attention to those. They obviously have something to do with salivation. This has to do with your pupil size. And this one we are going to pay attention to, the dorsal motor nucleus of the vagus, a little bit of attention. We don't actually test it. It controls basically all your internal organs. Then the general sensory nuclei, we've learned them today. The mesencephalic trigeminal, the main trigeminal sensory nucleus, and the spinal nucleus. They're all general sensory. What's general sensory? Fine touch, proprioception, pain, temperature, kinesthesia. And then special sensory, these are hearing and balance. And then nucleus solitarius for visceral sensory, sensation inside basically the gut, and your pharynx is part of the gut. Okay. All right, going to the next one. Now we're going to look at the last of the sensory pathways that are of concern to us, and this is the visual pathway controlled by the optic nerve, cranial nerve 2. And this is a kind of a complex visual figure, but we're going to spend a little time with it because after you have a good understanding of it and can follow it, it's really, really helpful and will help build your, I guess you'd say, your intuition or your feeling about how this system works. So I'm going to go through the language on the left side and then relate it to the figure. It sounds complex, but let's try to make it simple. First of all, I start out with the term temporal hemiretina. Each of your retina, which is where all your rods and cones and the specialized organs that code for light, each of your retina can be divided into two, a right and a left side. So each one is a hemiretina, and there's an imaginary line, it's not a real line, coming right down the center, which divides inside your eyeball, one hemiretina from the other. So each eyeball has two hemiretina, and they are labeled temporal, the side that's out to the side, and nasal, the one that's up more toward the nose. Let's relate that down here to this image. Here is sort of a horizontal section through the whole system, including the eyeball. And here is a nasal hemiretina. Here is a lateral hemiretina. Nasal hemiretina, lateral hemiretina. So now what this says is each temporal hemiretina projects to the ipsilateral lateral geniculate body. Let's see how that gets color coded. Here is a lateral hemiretina, color coded black, and it's tracked the neurons back, because this represents neurons, and they go back here, and they don't go across the midline, they go back here. Now, what is that? That is the thalamus. And in particular, it's the lateral geniculate body of the thalamus. The lateral geniculate body is a nucleus of the thalamus. I haven't been naming many of them, but let's do this one. It's very common, and you can learn that. It's the lateral geniculate body of the thalamus. And that's the way station in the visual pathway, a very important one, obviously. If you get interrupted there, you're not going to have a part of your visual field for sure. So that's what this first sentence or point makes, is that each lateral hemiretina projects to the ipsilateral. Let's go over here. Now, here is a lateral hemiretina of the other eye, and it's projecting to the ipsilateral lateral geniculate body. Okay, so that's point number one. Point number two, each nasal hemiretina projects to the contralateral geniculate body. In other words, there's a crossing. Now let's see how that works here. This is, I don't know, you have to look pretty close, but that's blue, and the blue crosses. So that's trying to show you that the neurons that start out in the nasal hemiretina of this left eye are going to end up in the thalamus on the opposite side. And obviously they decussated, they crossed. And they crossed in this area called the optic chiasm. Optic chiasm. I believe I've got the language there someplace. And, oh yeah, here, well, it's labeled optic chiasm. Okay. So far, so good. Okay, now each lateral geniculate body projects via the optic radiation within the internal capsule, by the way, there's that internal capsule again, back to the ipsilateral Brodmann's area 17. Okay, so what they're trying to show is that once the pathway reaches the thalamus, the second order neurons all project back to the ipsilateral Brodmann's area 17. And they do go through the internal capsule. Optic radiation is part of the internal capsule. You can see where the damage that involves internal capsule, and it's a particular kind of stroke, we'll see it often actually, creates a very distinct pattern of deficits. Okay, now we've got almost all the connections in the brain made here. So what we're going to do now is relate the visual fields to this system. Here's a visual field, and they're using the same color coding. How your visual field, you should think about your visual field as I want you just to look straight ahead at a point on the wall and then draw a vertical line through the point. Everything on the right side of that vertical line is your right visual field. Everything on the left side of the line is your left visual field. That is what they're showing. So here, this individual is looking right here, and let us imagine that they have in their right visual field a butterfly. You put a picture of a butterfly on the wall on the right of the focal point. The other side has a flower picture on the wall to the left of the focal point. And they're trying to show that the left visual field is being projected by this pathway we just explored back to the contralateral primary visual receiving area, BA17. And vice versa. The right visual field is being projected back here. Okay, so that's basically, that's the pathway. I didn't mean to do that. That's the pathway, that's the connection, that's how your visual fields project back to the primary visual receiving area, BA17. Right visual field goes to the left side, left visual field goes to the right side, and that's it. Now let's look at the effect of lesions in different areas. I want to make sure I didn't skip a slide. Did I skip a slide? Okay. All right. Now, here's in the first example. Let us imagine, and here it's labeled number 1. And so this is called an optic nerve. Note the label. This is called an optic tract. So if you're talking about the visual pathway central to the optic chiasm, the pathway is labeled the optic tract. If you're talking about the visual pathway distal to the optic chiasm, the pathway is labeled the optic nerve. We've all heard of the optic nerve, probably not so much the optic tract. So number 1 is let's just call it a lesion of the right optic nerve. What will be the pattern of visual field defects? It's shown right here. And it's kind of obvious. They are blind in the right eye. So if they're looking at the focal point, just shut your eye. You're still looking at the focal point, and you still see a lot of things to the right of that vertical line. You don't lose the whole visual field. You lose the right eye. So you could see exactly what's left. But I'm just reminding you, look straight ahead at a particular point, then close your right eye. That's what the deficit would be. They don't lose the right visual field. They lose the vision in the right eye. Okay, so that's conceptually quite easy. Let's go to number 3. I'm going to skip number 2 for a moment. Let's go to number 3, because this is actually the pattern that you're going to see time and time again. This is an injury of the pathway central to the chiasm. So it can be where where do they have number 3? Right here. Right here. It could also be the entire internal capsule or the optic radiation part of the internal capsule. It could also be a posterior part of the cerebrum, knocking out Brodmann's area 17 minimally, other things too, but minimally. The pattern of visual field loss will be the same. And that pattern will be represented here. Okay, so number 3 is the damage is on the right side of the pathway, central to the optic chiasm. Here is the visual field loss. They lose the left visual field. Now, you can't mimic that by just closing your left eye. You could, if you had glasses on, like I do, put a piece of tape on the left side of each lens and put it at exactly the point of that imaginary line so it comes up to that imaginary line. That's what it feels like to have a left hemianopia. Most people who have a left hemianopia are able to compensate for it. They seem to have an awareness that they have lost a part of their visual field. And how do you compensate for it? Well, you turn your head or your eyes. You can still turn your eyes. I'm making you not do it. I'm making you focus on one focal point and not turn your eyes. But if you turn your eyes, you can compensate for it. I don't want to say perfectly, but you can compensate for it. In other words, people can still read, for example. They still scan and they can still read. If you have damage on the right side of the brain, you can certainly have a what's called a hemianopia, blindness on the left visual field. That person tends to not compensate for it. They will demonstrate it in very interesting ways by, for example, If you put a plate of food in it, now keep in mind they have a left hemianopia. You put a plate of food in front of them, they will eat on the right side of the plate, right up to the midline and not beyond, seeming not to recognize that there's a left side there. If they were compensating, they would simply turn their eyes and they would be able to see it. But if you're not compensating, you don't see it. So there are other manifestations like that, but we're going to keep it simple right now, not get too clinical. I want to give one more example, which you will not see very often. I've seen a couple and they were coincidental to what I was seeing them for, but they had a pituitary tumor. The pituitary gland is located right by that chiasm. And a pituitary tumor can then, in effect, functionally transect these decussating neurons. Now, what is going through there? The feel, I'm stuttering. The neurons that originated from the nasal hemiretina. And here would be their pattern of visual field loss. They have what is commonly referred to as tunnel vision. In other words, they lose the periphery in both eyes. And so that's what they get. Now, that if you can spend a little time and understand that, you know the system really well. That's it. But like I said, clinically, we're not going to see that very often. We're going to see, well, we'll see people who have blindness in one eye, of course, once in a while, and we'll see this pattern shown in number 3, a hemianopia, very, very frequently. These are more detailed, but we're going to ignore them down there 4, 5, and 6. All right. Now, here are your quiz questions. So I'm going to leave that to you, and we will start with those and answer other questions, etc. Of course, when we get together for live class. All right. I'm bringing this back here. Screen share.